Alright, Chapter 13, Depressive Disorders. Woo! Key terms and concepts. Affect, anergia, anhedonia, dysrhythmic disorder or DD, hypersomnia, light therapy, major depressive disorder MDD, mood disorders, psychomotor agitation, psychomotor retardation, selective serotonin reuptake inhibitors, SSRIs, transcranial magnetic stimulation, TMS, tricyclic antidepressants, TCAs, vagus nerve stimulation, VNS, vegetative signs of depression. No textbook chapter can adequately convey the personal pain and suffering experienced by the individual with depression, not to mention the pain, helplessness, and frustration felt by the affected individual's friends and loved ones. However, it is essential for nursing students to gain a fundamental understanding of this group of disorders. People with ethnicities, cultures, ages, people of all ethnicities, cultures, ages, socioeconomic groups, education levels, and geographic areas are susceptible to depressive episodes, but some individuals are more susceptible than others. Virtually all nurses will come into contact with patients with depression, or whose primary condition is complicated by depression. This chapter includes basic information and therapeutic tools that will facilitate the care of patients with depression. Clinical picture. Figure 13.1 presents diagnostic criteria for major depressive disorder and dysthymic disorder. The two depressive disorders defined by the DSM, 4th edition. Several subtypes of major depressive disorder, as well as other proposed depressive types currently being researched to determine whether they should be considered disorders, are described in detail in this chapter. Major depressive disorder. Patients with major depressive disorder, or MDD, experience substantial pain and suffering, as well as psychological, social, and occupational disability. A patient with MDD presents with a history of one or more major depressive episodes and no history of manic or hypomanic episodes. In MDD, the symptoms interfere with the person's social or occupational functioning and in some cases may include psychotic features. Delusional or psychotic major depression is a severe form of mood disorder, characterized by delusions or hallucinations. For example, patients might have delusional thoughts that interfere with their nutritional status, e.g., God put snakes in my stomach and told me not to eat. The emotional, cognitive, physical, and behavioral symptoms experienced during a major depressive episode represent a change in the person's usual functioning. The course of MDD is variable. At least 60% of people can expect to have a second episode. Individuals who have experienced 2 episodes of major depression have a 70% chance of experiencing a third. And those who have had 3 episodes have a 90% chance of future episodes. Subtypes. The diagnosis for MDD may include one of the following specifiers to describe the most recent episode of depression. Psychotic features. Indicates the presence of disorganized thinking delusions, e.g. delusions of guilt or being punished for sins, somatic delusions of horrible disease or body rotting, delusions of poverty or going bankrupt, or hallucinations, usually auditory voices berating person for sins. Melancholic features. This outdated term indicates a severe form of endogenous depression, which means not attributable to environmental stressors, characterized by severe apathy, weight loss, profound guilt, symptoms that are worse in the morning, early morning awakening, and often suicidal ideation. Atypical features refers to people who have a dominant vegetative symptoms, overeating and oversleeping. Onset is younger, psychomotor activities are slow, and anxiety is often an accompanying problem, which may cause misdiagnosis. Catatonic features marked by non-responsiveness, extreme psychomotor retardation, may seem paralyzed, withdrawal, and negativity. Postpartum onset indicates onset within 4 weeks after childbirth. It is common for psychotic features to accompany this depression. Severe ruminations or delusional thoughts about the infant signify increased risk of harm to the infant. Seasonal features. Seasonal affective disorder, or SAD, indicates that episodes mostly begin in fall or winter and remit in spring. These patients have reduced cerebral metabolic activity. SAD is characterized by anergia, hypersomnia, overeating, weight gain, and a craving for carbohydrates, a response to light therapy. Considering culture. Postpartum depression in immigrant women. Women who deliver a baby in a country different from the one in which they were born may be at higher risk for postpartum depression, PPD. Various studies have shown that among immigrant populations, postpartum depression rates are around 37%, compared to 7% among non-immigrants. Research shows that risk factors for PPD are same for immigrants as non-immigrants, especially prenatal depression, anxiety, somatic symptoms, and marital relationship. So why is there a higher rate in immigrant women? One reason is a lack of support. Immigrant women report support networks as strong and as large as non-immigrant women. However, a larger proportion of the social network is located in a different country. This can put a strain on a marital relationship because immigrant women may expect and need more support from their spouses. Husbands may not be prepared to take on this kind of supportive role required by their wives. It may be hard to detect PPD in immigrant women because of language barriers and because PPD may manifest itself in somatic complaints. Zolkowitz and colleagues found that immigrant women with PPD had more somatic complaints than women who did not have depression. Immigrant women have special needs because of language barriers, geographically distant support networks, increased somatic symptoms, and paternal role strain. Nurses can design interventions geared toward increasing support and alleviating physical complaints of female immigrants who have recently delivered. Stability and change in depressive symptoms from pregnancy to 2 months postpartum. Oh, never mind. That's just the name of the article. Proposed subtypes. The following subtypes of MDD represent areas of dysfunction proposed by clinicians and researchers and are currently being researched for inclusion as diagnoses in the 5th edition of the DSM. V. Okay, so premenstrual dysphoric disorder, characterized by more severe symptoms than premenstrual syndrome. Symptoms begin toward last week of luteal phase, are absent in the week following menses, and include depressed mood, anxiety, affective lability, or persistent and marked anger or irritability. Other symptoms include anergia, overeating, difficulty concentrating, and feeling out of control or overwhelmed, among others. Mixed anxiety depression. Prevalence of 5% has been estimated, characterized by significant functional disability. Criteria include at least 1 month of persistent dysphoric mood, and with possible hypervigilance, difficulty concentrating, fatigue, low self-esteem, and irritability, among others, all of which cause significant distress or impairment in functioning. Recurrent brief depression meets criteria for MDD, but episodes last 1 day to 1 week. Depressive episodes must occur at least once per month over 12 months or more carries a high risk for suicide. Minor depression, characterized by sustained depressed mood without the full depressive syndrome. Pessimistic attitude and self-pity are required for the diagnosis. May be chronic and may be complicated by a superimposed major depressive episode. Dysthymic disorder. Dysthymic disorder, or DD, is characterized by a chronic depressive syndrome that is usually present for most of the day, more days than not, for at least 2 years. The depressive mood disturbance, because of its chronic nature, cannot be distinguished from the person's usual pattern of functioning. I've always been this way. Quote, although people with dysthymia suffer from social and occupational distress, it is not usually severe enough to warrant hospitalization unless the person becomes suicidal. The age of onset is usually from early childhood and teenage years to early adulthood. Patients with DD are at risk for developing major depressive episodes and other psychiatric disorders. Differentiating MDD from DD can be difficult because the disorders have similar symptoms. The main differences are in the duration and severity of the symptoms. Epidemiology. Depression is the leading cause of disability in the United States. Lifetime prevalence of a major depressive episode, or the total number of people in the United States who will experience the disorder within their lifetime, is 8.6%. Studies find that MDD is twice as common in women, 11.2%, as in men, 6%, although one may question the validity of these statistics, considering that men commit suicide at a far higher rate than women. The CMHS has determined that, that's the Center for Mental Health Services, has determined that MDD and DD tend to have higher prevalence rates in lower income groups. DD, chronic mild depression, occurs in about 3.4% of people during their lifetimes. About 40% of people with DD also meet the criteria for MDD or bipolar disorder, BD, in any given year. Children and adolescents. Children as young as 3 years of age have been diagnosed with depression. MDD is said to occur in as many as 18% of pre-adolescents, which is perhaps a low estimate because depression in this age group is often underdiagnosed. Children and adolescents between 9 and 17 years of age have a 6% prevalence of depression and 4.9% have MDD. Girls 15 years and older are twice as likely to experience a major depressive episode as boys. The dominant symptom of depression in childhood and adolescence tends to be irritability. Older adults. Although depression in older adults is common, it is not a normal result of aging. It is estimated that of the 35 million people over the age 65, 2 million, almost 6%, suffer from severe depression, and another 5 million, around 14%, suffer from less severe forms of depression. Many older adults suffer from subsyndromal depression, in which they experience many but not all the symptoms of a major depressive episode. These individuals have an increased risk of developing major depression, and a disproportionate number of older adults with depression are likely to die by suicide. Unfortunately, the symptoms of depression often go unrecognized in this population, although older adults generally make frequent medical visits. Thus, older individuals suffering from depression are at risk for being untreated. Comorbidity. A depressive syndrome frequently accompanies other psychiatric disorders such as anxiety disorders, schizophrenia, substance abuse, eating disorders, and schizoaffective disorder. People with anxiety disorders, e.g. panic disorder, generalized anxiety disorder, obsessive compulsive disorder, commonly present with depression, as do people with personality disorders, particularly borderline personality disorder, adjustment disorder, and brief depressive reactions. Mixed anxiety depression is perhaps one of the most common psychiatric presentations. Symptoms of anxiety occur in an average of 70% of cases of major depression. The presence of comorbid anxiety disorder and depression has a Negative impact on the disease course. Comorbidity has been shown to result in a higher rate of suicide, greater severity of depression, greater impairment in social occupational functioning, and poorer response to treatment. This is especially true in older adults with depression who have concurrent symptoms of anxiety or an anxiety disorder. Excuse me. The incidence of major depression greatly increases with the occurrence of a medical disorder. The people with chronic medical problems are at higher risk of depression than those in the general population. Depression is often secondary to a medical condition and may also be secondary to use of substances such as alcohol, cocaine, marijuana, heroin, and even anxiolytics and other prescription medications. Table 13.1. Depression can also be a sequela or consequence of bereavement and grief. Chapter 32 has an in-depth discussion of end-of-life issues and bereavement. Etiology. Although many theories attempt to explain the cause of depression, many psychological, biological, and cultural variables make identification of one cause difficult. Furthermore, it is unlikely there is a single cause for depression. The high variability in symptoms, response to treatment, and course of the illness supports the supposition that depression may result from a complex interaction of causes. For example, genetic predisposition to the illness combined with childhood stress may lead to significant changes in the central nervous system that result in depression. However, there seem to be several common risk factors for depression listed in box 13.1. Biological factors, genetic. Twin studies consistently show that genetic factors play a role in the development of depressive disorders. Various studies reveal that the average concordance rate for mood disorders among monozygotic twins sharing the same genetic material, is about 37%. That is, if one twin is affected, the second has a 37% chance of being affected as well. Increased heritability of mood disorders is associated with an earlier age of onset, greater rate of comorbidity, and increased risk of recurrent illness. For depression to develop, however, a genetic predisposition must also be affected by environmental factors. Table 13.1. Depression secondary to medical conditions and substances / medication. Neurological medical conditions, epilepsies, Parkinson's disease, multiple sclerosis, Alzheimer's disease. Infectious or inflammatory, neurosyphilis, AIDS. Cardiac disorders, ischemic heart disease, cardiac failure, cardiomyopathies. Endocrine, hypothyroidism, diabetes mellitus, vitamin deficiencies, parathyroid disorders. Inflammatory disorders, collagen, vascular diseases, irritable bowel syndrome, chronic liver disorders. Neoplastic disorders, CNS tumors, paraneoplastic syndrome. Okay, now on to substances and medications. Central nervous system depressants, alcohol, barbiturates, benzodiazepines, clonidine. Central nervous system medications, amantadine, bromocriptine, levodopa, phenothiazines, phentoin. Psychostimulants, amphetamines, systemic medications, corticosteroids, digoxin, diltiazem, enalapril, ethionamide, isotretinoin, mefloquine, methyldopa, metoclopramide, quinolones, Respirine, statins, thiazides, vincristine. So all those things can be secondary, or depression secondary to medical conditions and substance medications. Okay, biochemical. The brain is a highly complex organ that contains billions of neurons. There is much evidence to support the concept that many CNS neurotransmitter abnormalities may cause clinical depression. These neurotransmitter abnormalities may be the result of genetic or environmental factors, or even of other medical conditions, such as cerebral infarction, hypothyroidism, acquired immune deficiency syndrome, or drug use. Primary risk factors for depression. This is box 13.1. Primary risk factors for depression: female gender, being unmarried, low socioeconomic class, early childhood trauma, the presence of a negative life event, especially loss and humiliation, family history of depression, especially in first-degree relatives, high levels of neuroticism, predisposition to respond to stress poorly, postpartum period, medical illness, absence of support, social support, alcohol or substance abuse. Well, all of that is completely not biological at all. Okay. Specific neurotransmitters in the brain are believed to be related to altered mood states. Two of the main neurotransmitters involved are serotonin, which is 5-HT, and norepinephrine. Serotonin is an important regulator of sleep, appetite, and libido. Therefore, serotonin circuit dysfunction can result in sleep disturbances, decreased appetite, and low sex drive, poor impulse control, and irritability. Norepinephrine modulates attention and behavior. It is stimulated by stressful situations, which may result in overuse of a deficiency of norepinephrine. A deficiency, an imbalance as compared to other neurotransmitters, or an impaired ability to use available norepinephrine, can result in apathy, reduced responsiveness, and slowed psychomotor activity. At present, research suggests that depression results from the dysregulation of a number of neurotransmitter systems in addition to serotonin and norepinephrine. The dopamine, acetylcholine, and GABA systems are also believed to be involved in the pathophysiology of a major depressive episode. Stressful life events, especially losses, seem to be a significant factor in the development of depression. Norepinephrine, serotonin, and acetylcholine play a role in stress regulation. When these neurotransmitters become overtaxed through stressful events, neurotransmitter depletion may occur. Excuse me. At this time, no single mechanism of depressant action has been found. The relationships among the serotonin, norepinephrine, dopamine, acetylcholine, and GABA systems are complex and need further assessment and study. However, treatment with medication that helps regulate these neurotransmitters has proved empirically successful in the treatment of many patients. Figure 13.2 shows a positron emission tomographic or PET scan of the brain of a woman with depression before and after taking medication. Excuse me. Refer to Figure 3.7 for PET scans comparing brain activity in an individual with depression and an individual without depression. And 13.2 shows that during depression, much less activity in the brain. Alterations in hormonal regulation. Although neuroendocrine findings are as yet inconclusive, the neuroendocrine characteristic most widely studied in relation to depression has been hyperactivity of the hypothalamic pituitary adrenal cortical axis. People with major depression have increased urine cortisol levels and elevated corticotropin releasing hormone. Dexamethasone, an exogenous steroid that suppresses cortisol, is used in the dexamethasone suppression test for depression. Results of this test are abnormal in about 50% of people with depression, which indicates hyperactivity of the hypothalamic pituitary adrenal cortical axis. However, the findings may also be abnormal in people with obsessive compulsive disorder and other medical conditions. Significantly, patients with MDD with psychotic features are among those with the highest rates of non-suppression of cortisol on the dexamethasone suppression test. Diathesis Diathesis stress model. The diathesis stress model of depression takes into account the interplay of biology and life events in the development of depressive disorders. It is believed that psychosocial stressors and interpersonal events trigger neurophysical and neurochemical changes in the brain. Early life trauma may result in long-term hyperactivity of the CNS corticotropin-releasing factor, or CRF, and norepinephrine systems, with a consequent neurotoxic effect on the hippocampus, which leads to overall neuronal loss. These changes could cause sensitization of the CRF circuits to even mild stress in adulthood, leading to an exaggerated stress response. Interesting. According to the stress diathesis model, depression results from a dynamic interplay of biology and environment. Some people may be born with a predisposition towards depression, which is triggered by experiencing a stressful life event. The experience of depression further alters the neurological connections in the brain, increasing the predisposition toward depression. The result is a vicious cycle of recurrent depressive disorder. Early, effective treatment is needed to break the cycle. Psychological factors. Cognitive theory. In cognitive theory, the underlying assumption is that the person's thoughts will result in emotions. If a person looks at life in a positive way, the person will experience positive emotions, but negative interpretation of life events can result in sorrow, anger, and hopelessness. Cognitive theorists believe that people may acquire a psychological predisposition to depression due to early life experiences. These experiences contribute to negative, illogical, and irrational thought processes that may remain dormant until they are activated during times of stress. Beck found that persons with depression process information in negative ways, even in the midst of positive factors. He believed that automatic, negative, repetitive, unintended, and non-readily controllable thoughts perpetuate depression. 3 thoughts constitute Beck's cognitive triad. 1. A negative, self-depreciating view of self. 2. A pessimistic view of the world. 3. The belief that negative reinforcement or no validation for the self will continue in the future. Belief. That's three again. The belief that negative reinforcement or no validation for the self will continue in the future. Okay. Coming to realize that one has an ability to interpret life events in a positive way helps a person recognize that he or she has an element of control over emotions and therefore depression. Learned helplessness. An older but still plausible theory of depression is that of learned helplessness. Sigelman, 1973, stated that although anxiety is the initial response to a stressful situation, it is replaced by depression if the person feels no control over the outcome of the situation. A person who believes that an undesired event is his or her fault and that nothing can be done to change it is prone to depression. The theory of learned helplessness has been used to explain the development of depression in certain social groups, such as older adults, people living in impoverished areas, and women. Application of the nursing process. Assessment. Undiagnosed and untreated depression is often associated with more severe presentations of symptoms, greater risk of suicide, somatic problems, and severe anxiety or anxiety disorders. A study by Beige and Associates concluded that individuals with depression who manifested psychological symptoms were recognized as having depression 90% of the time, in contrast to those who showed somatic symptoms, e.g. chronic pain, insomnia, who were recognized as having depression 50% of the time, and those who had a medical disorder in whom depression was identified 20% of the time. General assessment. Assessment tools. Numerous standardized depression screenings tools that help assess the type of depression are available, including the Beck Depression Inventory, the Hamilton Depression Scale, the Zung Depression Scale, and the Geriatric Depression Scale. The Patient Health Questionnaire 9, PHQ-9, is a short inventory that highlights predominant symptoms seen in depression. It is presented here because of its ease of use, Figure 13.3. And that's a questionnaire. Skip over that. Assessment of suicide. I'll just tell you this. The scoring for it is 0 to 4 is no depression, 5 to 9 is mild, 10 to 14 is moderate, 15 to 19 is moderately severe, and 20 to 27 is severe. And that's the PHQ-9 score, depression thing. PHQ-9. Okay, assessment of suicide potential. The patient should always be evaluated for suicidal or homicidal ideation. About 15% of people with clinical depression commit suicide. Initial suicide assessment might include the following statements or questions. You have said you are depressed. Tell me what that is like for you. When you feel depressed, what thoughts go through your mind? Have you gone so far as to think about taking your own life? Do you have a plan? Do you have the means to carry out your plan? Is there anything that would prevent you from carrying out your plan? Refer to Chapter 24 for detailed discussion of suicide critical risk factors, warning signs, and strategies for suicide prevention. 13.1. Case Study in Nursing Care Plan, Depression. Mrs. Glessner is a 35-year-old executive secretary. She has been divorced for 3 years and has 2 sons, 11 and 13 years of age. She is brought into the emergency department, ED, by her neighbor. She has some slashes on her wrists and is bleeding. The neighbor states that both of Mrs. Glessner's sons are visiting their father for the summer. Mrs. Glessner has become more and more despondent since terminating a 2-year relationship with a married man 4 weeks previously. According to the neighbor, for 3 years after her divorce, Mrs. Glessner talked constantly about not being pretty or good enough and doubted that anyone could really love her. The neighbor states that Mrs. Glessner has been withdrawn for at least 3 years. After the relationship with her boyfriend ended, she became even more withdrawn and sullen. Miss Glessner is about 20 pounds overweight, and her neighbor states that Miss Glessner often stays awake late into the night, drinking by herself and watching television. She sleeps through most of the day on the weekends. After receiving treatment in the ED, Mrs. Glessner is seen by a psychiatrist. The initial diagnosis is dysthymic disorder with suicidal ideation. A decision is made to hospitalize her briefly for suicidal observation and evaluation for appropriate treatment. The nurse, Mrs. Ward, admits Miss Glessner to the unit from the ED. Nurse: Hello, Miss Glessner. I'm Marcia Ward. I'll be your primary nurse. Miss Glessner: Yeah, I don't need a nurse, a doctor, or anyone else. I just want to get away from this pain. Nurse: You want to get away from your pain? Yeah, I just said that, didn't I? Oh, what's the use? No one understands. Nurse: I would like to understand, Miss Glessner. Look at me. I'm fat, ugly, and no good to anyone. No one wants me. Who doesn't want you? My husband didn't want me, and now Jerry left me to go back to his wife. You think because Jerry went back to his wife that no one else could care for you? Well, he doesn't anyway. Because he doesn't care, you believe that no one else cares about you? Yes. Who do you care about? No one, except my sons. I do love my sons, even though I don't often show it. Tell me more about your sons. Mrs. Ward continues to speak with Miss Glessner. Miss Glessner talks about her sons with some affect and apparent affection. However, she continues to state that she does not think of herself as worthwhile. Assessment. Self-assessment. Miss Ward is aware that when patients have depression, they can be negative, think life is hopeless, and be hostile towards those who want to help. When Miss Ward was new to the unit, she withdrew from patients with depression and sought out patients who appeared more hopeful and appreciative of her efforts. The unit coordinator was very supportive of Miss Ward when she was first on the unit. Miss Ward, along with other staff, was sent to in-service education sessions on working with patients with depression and was encouraged to speak up in staff meetings about the feelings many of these patients evoked in her. As a primary nurse, she was assigned a variety of patients. She found that as time went on, with the support of her peers and the opportunity to speak up at staff meetings, she was able to take what patients said less personally and not feel so responsible when patients did not respond as fast as she would like. After 2 years, she had had the experience of seeing many patients who seemed hopeless and despondent on admission respond well to nursing and medical intervention and go on to lead full and satisfying lives. This also made it easier for Miss Ward to understand that even though the patient with depression may think life is hopeless and may believe there is nothing in life to live for, change is always possible. Objective data. Slashed her wrists. Recently broke off with boyfriend. Has thought poorly of herself for 3 years since divorce. Has 2 sons she cares about. Is 20 pounds overweight. Stays awake late at night drinking by herself. Has been withdrawn since divorce. Subjective data. No one could ever love me. I'm not good enough. I just want to get rid of this pain. I'm fat and ugly, no good to anyone. I do love my sons, although I don't always show it. Diagnosis. The nurse evaluates Miss Klessner's strengths and weaknesses and decides to concentrate on 2 initial nursing diagnoses that seem to have the highest priority. Risk for suicide related to separation from 2-year relationship as evidenced by actual suicide attempt. Slashed her wrists, recently broke off with a boyfriend, drinks at night by herself, withdrawn for 3 years since divorce. And 2, situational low self-esteem related to divorce and recent termination of love relationship, as evidenced by derogatory statements about self. I'm not good enough. No one could ever love me. I'm fat and ugly. No good to anyone. I do love my sons, although I don't always show it. Outcomes identification. Patient refrains from attempting suicide. Planning. Because Ms. Klessner is discharged after 48 hours, the issue of disturbance in self-esteem continues to be addressed in her therapy after discharge. Ms. Ward later reviews the goals for her work with Ms. Klessner in the community. Implementation. Ms. Klessner's plan of care is personalized as follows. Short-term goal. Patient expresses at least one reason to live, and this is apparent by the 2nd day of hospitalization. Intervention. Observe patient every 15 minutes while she is suicidal. Remove all dangerous objects from patient. Obtain a no self-harm contract with patient for a specific period of time to be renegotiated. Spend regularly scheduled periods of time with patient throughout the day. Assist patient in evaluating both positive and negative aspects of her life. Encourage appropriate expression of angry feelings. Accept patient's negativism. And rationales for those are: patient safety is ensured. Impulsive self-harmful behavior is minimized. May help patient gain a sense of control and a feeling of responsibility. This interaction, which is spend regular time with her, reinforces that patient is worthwhile and builds up experience to begin to relate better to nurse on a one-on-one basis. A person with depression is often unable to acknowledge any positive aspects of life unless they are pointed out by others. Providing for expression of pent-up hostility in a safe environment can reinforce more adaptive methods of releasing tension and may minimize need to act out self-directed anger. Acceptance enhances feelings of self-worth. All right, the second goal. Patient will identify 2 outside supports she can call upon if she feels suicidal in the future. This explores usual coping behaviors, or you can explore usual coping behaviors, rationale, behaviors that need reinforcing, and new coping skills that need to be introduced can be identified. Next intervention, assist patient in identifying members of her support system. Strengths and weaknesses of support available can be evaluated. Also suggests a number of community-based support groups she might wish to discuss or visit, e.g. hotlines, support groups, women's groups. The patient needs to be aware of community supports to use them. You can assist patient in identifying realistic alternatives she is willing to use. Unless patient is in agreement with any plan, she will be unable or unwilling to follow through in a crisis. Evaluation. During the course of her work with Miss Ward, Miss Klessner decides to go to some meetings of Parents Without Partners. She states that she is looking forward to getting back to work and feels much more hopeful about her life. She has also lost 3 pounds while attending Weight Watchers. She states, I need to get back into the world. Although Miss Klessner still has negative thoughts about herself, she admits to feeling more hopeful and better about herself, and she has learned important tools to deal with her negative thoughts. Key assessment findings. A depressed mood and anhedonia are the key symptoms of depression. Almost 97% of people with depression have anergia, lack of energy or passivity. Anxiety, a common symptom in depression, is seen in about 60 to 90% of patients with depression. When people experience a depressive episode, their thinking is slow, and their memory and concentration are usually negatively affected. They also dwell on and exaggerate their perceived faults and failures, and are unable to focus on their strengths and successes. A person with major depression may experience delusions of being punished for doing bad deeds or being a terrible person. Feelings of worthlessness, guilt, anger, and helplessness are common. Psychomotor agitation may be evidenced by constant pacing and wringing of hands. The slowed movements of psychomotor retardation, however, are more common. Somatic complaints, headaches, malaise, backaches are also common. Vegetative signs of depression, change in bowel movements and eating habits, sleep disturbances, and disinterest in sex are usually present. In primary care, people with MDD experience chronic pain at a rate of 66% and disabling pain at a rate of 41%, compared to 43% and 10%, respectively, of patients who do not have depression. Areas to assess. Affect. Affect is the outward representation of a person's internal state of being and is an objective finding based on the nurse's assessment. A person who has depression sees the world through gray-colored glasses. Posture is poor and the patient may look older than the stated age. Facial expressions convey sadness and dejection, and the patient may have frequent bouts of weeping. Conversely, the patient may say that he or she is unable to cry. Feelings of hopelessness and despair are readily reflected in the person's affect. For example, the patient may not make eye contact, may speak in a monotone, may show little or no facial expression, flat affect, and may make only yes or no responses. Frequent sighing is common. Thought processes. During a depressive episode, the person's ability to solve problems and think clearly is negatively affected. Judgment is poor and indecisiveness is common. The individual may claim that the mind is slowing down. Memory and concentration are poor. Evidence of delusional thinking may be seen in a person with major depression. Common statements of delusional thinking are, I have committed unpardonable sins, God wants me dead, and I'm wicked and should die. Mood. Mood is the patient's subjective experience of sustained emotions or feelings. Feelings frequently reported by people with depression include anxiety, worthlessness, guilt, helplessness, hopelessness, and anger. Feelings of worthlessness range from feeling inadequate to having an unrealistically negative evaluation of self-worth. These feelings reflect the low self-esteem and is a painful partner to depression. Statements such as, I am no good, I'll never amount to anything, are common. Feelings. Guilt is a common accompaniment to depression. A person may ruminate over present or past failings. Extreme guilt can assume psychotic proportions, e.g., I have committed terrible sins and God is punishing me for my evil ways. Helplessness is evidenced by the inability to carry out the simplest tasks, e.g., grooming, doing homework, working, caring for children. Because they seem too difficult to accomplish, with feelings of helplessness come feelings of hopelessness, which are particularly correlated with suicidality. Even though most depressive episodes are time-limited, people experiencing them believe things will never change. This feeling of utter hopelessness can lead people to view suicide as a way out of constant mental pain. Hopelessness, one of the core characteristics of depression and risk factors for suicide, is a combined cognitive and emotional state that includes the following attributes. Okay, so the last one was helplessness. Now we're on to hopelessness. Negative expectations for the future, loss of control over future outcomes, passive acceptance of the futility of planning to achieve goals, emotional negativism as expressed in despair, despondency, or depression. Anger and irritability are natural outcomes of profound feelings of helplessness. Anger in depression is often expressed inappropriately through destruction of property, hurtful verbal attacks, or physical aggression toward others. However, anger may be directed toward the self in the form of suicidal or sub-suicidal behaviors. e.g., alcohol abuse, substance abuse, overeating, smoking. These behaviors often result in feelings of low self-esteem and worthlessness. Physical behavior. Lethargy and fatigue may result in psychomotor retardation, in which movements are extremely slow, facial expressions are decreased, and gaze is fixed. The continuum of psychomotor retardation may range from slowed and difficult movements to complete inactivity and incontinence. Psychomotor agitation, in which patients constantly pace, bite their nails, smoke, tap their fingers, or engage in some other tension-relieving activity, may also be observed. At these times, patients commonly feel fidgety and unable to relax. Grooming, dress, and personal hygiene are markedly neglected. People who usually take pride in their appearance and dress may be poorly groomed and allow themselves to look shabby and unkempt. Vegetative signs of depression are universal. Vegetative signs refer to alterations in those activities necessary to support physical life and growth: eating, sleeping, elimination, sex. For example, changes in eating patterns are common. About 60 to 70% of people with depression report having anorexia. Overeating occurs more often in DD. Changes in sleep patterns is a cardinal sign of depression. Often people experience insomnia, wake frequently, and have a total reduction in sleep, especially deep stage sleep. One of the hallmark symptoms of depression is waking at 3 or 4 a.m. and then staying awake or sleeping for only short periods. The light sleep of a person with depression tends to prolong the agony of depression over a 24-hour period. For some, sleep is increased. Hypersomnia and provides an escape from painful feelings. In any event, sleep is rarely restful or refreshing. Changes in bowel habits are common. Constipation is seen most frequently in patients with psychomotor retardation. Diarrhea occurs less frequently, often in conjunction with psychomotor agitation. Interest in sex declines, loss of libido during depression. Some men experience impotence, and a declining interest in sex often occurs among both men and women, which can further complicate marital and social relationships. Communication. A person with depression may speak and comprehend very slowly. The lack of an immediate response to the patient to a remark does not necessarily mean the patient has not heard or chooses not to reply. The patient may need more time to comprehend what was said and then compose a reply. In extreme depression, however, a person may become mute. Religious beliefs and spirituality. The role of religious beliefs and spirituality in depression is just beginning to be understood. Erhard and Treichel found that among people with depression, there was a concern with spiritual questions such as, what is the meaning of life? The author concluded that people with depression and anxiety, like people with other serious illnesses, are concerned with the greater meaning of their experience and look beyond themselves for answers. Doolittle and Farrell found that certain aspects of faith and religious beliefs, such as belief in a higher power, belief in prayer, and the ability to find meaning in suffering, were associated with lower rates of depression. Nurses must assess patients' spiritual health by asking how their depression has affected their faith. Encouraging a connection with religious or spiritual practices that have brought them comfort in the past may be therapeutic. Age considerations. Assessment of children and adolescents. Depression often is overlooked in children and adolescents because mood changes in children are frequently seen as behavioral problems, and in adolescents as part of normal development. Although children with depression may display irritability and disruptive behavior, sadness and hopelessness are often the core issues. Although it is normal for teens to experience a degree of mood lability, adolescents with depression will have a sustained change in mood, thinking, and motivation. They may become sexually promiscuous or engage in alcohol or substance abuse. Both age groups may withdraw from friends and become preoccupied with death. Assessment of older adults. It can be easy to overlook depression in older adults because they are more likely to complain of aches and pains than acknowledge feelings of sadness or grief. Depression may exist alongside other illnesses or occur as the result of vascular changes in the brain. Patients and healthcare professionals may falsely believe that depression is a normal part of aging, but the nurse must assess older adults to see if the level of functioning represents a change from normal patterns. Evidence-based practice, depression, spirituality, and symptom burden. The contribution of depression and spirituality to symptom burden and chronic heart failure. Archives of Psychiatric Nursing. Problem. Heart failure, HF, adds greatly to disease burden in the United States, while the role of psychological factors and symptom burden in chronic illness has been explored. The role of spirituality is less well understood. Purpose of study. The purpose of the study was to see if spirituality had any relationship to depression and symptom burden in patients with HF. Methods. Adults with HF attending an outpatient clinic were recruited to participate in this exploratory correlational study. The 102 participants completed questionnaires to measure depression, spiritual beliefs, and symptom burden. Key findings. There was a positive correlation between depression scores and the frequency and intensity of HF symptoms. There was not a significant relationship between spirituality and the symptom burden. However, the interaction between depression and spirituality accounted for a greater variance in symptom burden than depression alone. In other words, if a person had a higher depression score, spiritual beliefs appeared to have an influence on symptom burden. Implications for nursing practice. When symptoms of heart failure worsen, it is usually assumed that the underlying pathology is physical, but this study underscores the fact that heart failure patients need to be screened and treated for depression. Nurses can assess for symptoms of depression in patients with HF, thus contributing to appropriate reduction in symptom burden. Self-assessment. Patients with depression often reject the advice, encouragement, and understanding of the nurse and others, and they often do not appear to respond to nursing interventions and seem resistant to change. When this occurs, you may experience feelings of frustration, hopelessness, and annoyance. These problematic responses can be altered by the following: recognizing any unrealistic expectations for yourself or the patient, identifying feelings that originate with the patient, understanding the roles biology and genetics play in the precipitation and maintenance of a depressed mood, unrealistic expectations of self. Nursing students and others new to caring for individuals with depression may have unrealistic expectations of themselves and their patients, and problems result when these expectations are not met. Unmet expectations usually result in a nurse feeling anxious, hurt, angry, helpless, or incompetent. Unrealistic expectations of self and others may be held even by experienced healthcare workers, and this phenomenon contributes to staff burnout. Many of your nursing expectations may not be conscious, but when these expectations are made conscious and are worked through with peers and more experienced clinicians or supervisors, more realistic expectations can be formed and attainable outcomes identified. Realistic expectations of self and the patient can decrease feelings of helplessness and increase a nurse's self-esteem and therapeutic potential. Feeling what the patient is feeling. It is not uncommon for nurses and other health professionals to experience intense anxiety, frustration, annoyance, hopelessness, and helplessness. While caring for individuals with depression, nurses empathetically sense what the patient is feeling. The novice nurse may interpret these emotions as personal reactions toward the patient with whom he or she is working. However, these feelings can be important diagnostic clues to the patient's experience. You can discuss feelings of annoyance, helplessness, and hopelessness with peers and supervisors to separate personal feelings from those originating with the patient. If personal feelings are not recognized, named, and examined, withdrawal by the nurse is likely to occur. Vignette. Juanita is working with David, a patient with depression who is living at a homeless shelter after losing his job and being evicted from his apartment. David expresses a lot of hopelessness about his future and believes he will never get another job or be able to live on his own. During clinical conference, Juanita states that she is feeling threatened and frustrated because David rejects her suggestions and her attempts to help. She confesses that she thinks David is not trying to feel better or improve his situation. Juanita spends time reviewing the illness of depression, common behaviors, and patient needs. She also reviews the recovery model of mental illness. In subsequent visits, she refocuses on David and stops giving him suggestions. After 4 weeks, David has worked out a plan to live with relatives while he undergoes vocational training. He thanks Juanita for listening and not making him feel like a failure. People instinctively avoid situations and persons that arouse feelings of frustration, annoyance, or intimidation. If the nurse also has an unresolved feelings of anger and depression, the complexity of the situation is compounded. There is no substitute for competent and supportive supervision to facilitate growth, both professionally and personally. Supervision by a more experienced clinician and sharing with peers help minimize feelings of confusion, frustration, and isolation, and can increase your therapeutic potential and self-esteem while you care for individuals with depression. Assessment guidelines: depression. Always evaluate the patient's risk of harm to self or others. Overt hostility is highly correlated with suicide. Depression is a mood disorder that can be secondary to a host of medical or other psychiatric disorders, as well as medications. A thorough medical and neurological examination helps determine if the depression is primary or secondary to another disorder. Essentially, evaluate whether the patient is psychotic, the patient has taken drugs or alcohol, medical conditions are present, the patient has a history of a comorbid psychiatric syndrome, eating disorder, borderline, or anxiety disorder. Assess the patient's past history of depression and determine what happened and what worked and did not work. Assess support systems, family, significant others, and need for information and referrals. Diagnosis. Depression is a complex disorder, and individuals with depression have a variety of needs. Therefore, nursing diagnoses are many. However, a high priority for the nurse is determining the risk of suicide, and the nursing diagnosis of risk of suicide is always considered. Refer to Chapter 24 for assessment guidelines and interventions for suicidal individuals. Other key targets for nursing interventions are represented by the diagnosis of hopelessness, ineffective coping, social isolation, spiritual distress, and self-care deficit, bathing, dressing, feeding, toileting. Table 13.2 identifies signs and symptoms commonly experienced in depression and offers potential nursing diagnoses. Table 13.2 Potential nursing diagnoses for depression. Signs and symptoms. Potential nursing diagnosis: risk for suicide. Signs and symptoms: previous suicidal attempts, putting affairs in order, giving away prized possessions. Risk for self-mutilation. Suicidal ideation, has planned ability to carry it out, overt or covert statements regarding killing self, feelings of worthlessness, hopelessness, and helplessness. disturbed thought processes. That would be lack of judgment, memory difficulty, poor concentration, inaccurate interpretation of environmental, negative negative ruminations, cognitive distortions, ineffective coping, interrupted family processes, risk for impaired attachment, ineffective role performance, decisional conflict. Those would be difficulty with simple tasks, inability to function at previous level, poor problem solving, poor cognitive function, verbalizations of inability to cope, difficulty making decisions, poor concentration, inability to take action, feelings of helplessness, hopelessness, powerlessness. More diagnoses: hopelessness, powerlessness, spiritual distress, impaired religiosity, risk for impaired religiosity, questioning of meaning of life and own existence, inability to participate in usual religious practices, conflict over spiritual beliefs, anger towards spiritual deity or religious representatives, chronic low self-esteem, situational low self-esteem. That would be feelings of worthlessness, poor self-image, negative sense of self, self-negating, verbalizations, feeling of being a failure, expressionless, or expressions of shame or guilt, hypersensitivity to slights or criticism, impaired social interaction, social isolation, risk for loneliness, withdrawal, non-communicativeness speech that is only in monosyllables, avoidance of contact with others, self-care deficit, bathing, dressing, feeding, toileting, imbalanced nutrition less than body requirements, disturbed sleep pattern, constipation, sexual dysfunction. Those signs are vegetative signs of depression, changes in sleeping, eating, grooming and hygiene, elimination, sexual patterns. Outcomes identification, the recovery model. The 2003 report from the President's New Freedom Commission on Mental Illness articulated that national health priorities should focus on recovery from mental illness rather than treatment of it. The recovery model emphasizes that healing is possible and attainable for individuals with mental illness, including depression. Recovery is attained through partnership with healthcare providers who focus on the patient's strengths. Treatment goals are mutually developed based on the patient's personal needs and values, and interventions are evidence-based. Remember that MDD can be a recurrent and chronic illness. Care should be directed not only at resolution, but the acute phase but also a long-term management. The nurse and the patient identify realistic outcome criteria and formulate concrete, measurable short-term and intermediate indicators. Each patient is different, and indicators should be selected according to individual needs. Table 13.3 presents some outcome criteria from the Nursing Outcomes Classification, NOC. Indicators for the outcomes of the vegetative or physical signs of depression, e.g. reports adequate sleep, are formulated to show, for example, evidence of weight gain, return to normal bowel activity, sleep duration of 6 to 8 hours per night, or return of sexual desire. Planning. The planning of care for patients with depression is geared toward the patient's phase of depression, particular symptoms, and personal goals. At all times during the care of a person with depression, nurses and members of the healthcare team must be cognizant of the potential for suicide. Assessment of risk for self-harm or harm to others is ongoing. A combination of therapy, cognitive, behavioral, and interpersonal, and psychopharmacological is an effective approach to the treatment of depression across all age groups. Table 13.3, NOC outcomes related to depression. Outcome and definition. Let's see. Depression, self-control. Personal actions to minimize melancholy and maintain interest in life events. Intermediate indicators: reports improved mood, adheres to therapy schedule, takes medication as prescribed, follows treatment plan. Short-term indicators: monitors intensity of depression, identifies precursors of depression, plans strategies to reduce effects of precursors, reports changes in symptoms to healthcare provider. Be aware that the vegetative signs of depression, changes in eating, sleeping, sexual satisfaction, as well as changes in concentration, activity level, social interaction, care for personal appearance, and so on, often need targeting. The planning of care for a patient with depression is based on the individual's symptoms and goals and attempts to encompass a variety of areas in the person's life. Safety is always the highest priority. Implementation. There are 3 phases in treatment and recovery from major depression. 1. The acute phase, 6 to 12 weeks, is directed at reduction of depressive symptoms and restoration of psychosocial and work function. Hospitalization may be required. 2. The continuation phase, 4 to 9 months, is directed at prevention of relapse through pharmacological therapy, education, and depression-specific psychotherapy. And 3. The maintenance phase, 1 year or more, of treatment is directed at prevention of further episodes of depression. It is important to keep in mind that both the continuation and maintenance phases are geared toward maintaining the patient as a functional and contributing member of the community after recovering from the acute phase. Counseling and communication techniques. Nurses often have great difficulty communicating with patients without talking. However, some patients with depression are so withdrawn that they are unwilling to or unable to speak, and just sitting with them in silence may seem like a waste of time or be uncomfortable. As your anxiety increases, you may start daydreaming, feel bored, remember something that must be done now, and so on. It is important to be aware that this time can be meaningful, especially if you have a genuine interest in learning about the patient with depression. It is difficult to say when a withdrawn patient will be able to respond. However, certain techniques are known to be useful in guiding effective nursing interventions. Some communication techniques to use with a severely withdrawn patient are listed in Table 13.4. Counseling guidelines for use with patients with a depression are offered in Table 13.5. Health teaching and health promotion. One basic premise of the recovery model of mental illness is that each individual controls his or her treatment based on individual goals. Within this model, health teaching is paramount because it allows patients to make informed choices. Health teaching is also an avenue for providing hope to the patient and should include: depression is an illness that is beyond a person's voluntary control. Although it is beyond voluntary control, depression can be managed through medication and lifestyle. Table 13.4. Guidelines for communication with severely withdrawn persons. Intervention. When a patient is mute, use the technique of making observations. There are many new pictures on the wall. You are wearing new shoes. Use simple, concrete words. Rationale. When a patient is not ready to talk, direct questions can raise the patient's anxiety level and frustrate the nurse. Pointing to commonalities in the environment draws the patient into and reinforces reality. Slowed thinking and difficulty concentrating impair comprehension. Intervention. Allow time for a patient to respond. Slowed thinking necessitates time to formulate a response. Intervention. Listen for covert messages and ask about suicide plans. People often experience relief and decrease in feelings of isolation when they share thoughts of suicide. Avoid platitudes such as, "Things will look up. Everyone gets down once in a while." Platitudes tend to minimize the patient's feelings and can increase feelings of guilt and worthlessness because the patient cannot look up or snap out of it. Table 13.5. Guidelines for counseling people with depression. Intervention. Help the patient question underlying assumptions and beliefs and consider alternate explanations to problems. This reconstructing a healthier and more helpful attitude about the future can alter depressed mood. Work with the patient to identify cognitive distortions that encourage negative self-appraisal. Cognitive distortions reinforce a negative, inaccurate perception of self in a world. For example, with this one, over age over generalizations, the patient takes one fact or event and makes a general rule out of it. He always, I never. Self-blame. The patient consistently blames self for everything perceived as negative. Mind reading. The patient assumes others don't like him or her without any real evidence that assumptions are correct. And discontinuing of positive attributes. The patient focuses on the negative. Encourage activities that can raise self-esteem. Identify need for A. problem-solving skills, B. coping skills, and C. assertiveness skills. Many people with depression, especially women, are not taught a range of problem-solving and coping skills. Increasing social, family, and job skills can change negative self-assessment. Encourage exercise, such as running and or weightlifting. Exercise can improve self-concept and potentially shift neurochemical balance. Encourage formation of supportive relationships, such as through support groups, therapy, and peer support. Such relationships reduce social isolation and enable the patient to work on personal goals and relationships needs. Provide information referrals when needed for religious or spiritual information, e.g. readings, programs, tapes, community resources. Spiritual and existential issues may be heightened during depressive episodes. Many people find strength and comfort in spirituality or religion. So back to health teaching. Illness management depends in large part on understanding personal signs and symptoms of relapse. Illness management depends on understanding the role of medication and possible medication side effects. Excuse me. Long-term management is best assured if the patient undergoes psychotherapy along with taking medications. Identifying and coping with the stress of interpersonal relationships, whenever they are familial, social, or occupational, is key to illness management. Including the family and discharge planning is also important and helps the patient in the following ways. Increases the family's understanding and acceptance of the family member with depression during the aftercare period. Increases the patient's use of aftercare facilities in the community. Contributes to higher overall adjustment in the patient after discharge. Promotion of self-care activities. In addition to feelings of hopelessness, despair, and physical discomfort, signs of physical neglect may be apparent. Nursing measures for improving physical well-being and promoting adequate self-care are initiated. Some effective interventions targeting physical needs are listed in Table 13.6. Nurses in the community can work with family members to encourage a family member with depression to perform and maintain his or her self-care activities. Milieu management. When a person has acute and severe depression, admission to an inpatient setting may be indicated. The patient with depression needs protection from suicidal acts in a supervised environment for regulating treatments. Often being removed from a stressful interpersonal situation increases the therapeutic value. Hospitals have protocols regarding the care and protection of the suicidal patient. See Chapter 24. Interventions targeting the vegetative signs of depression, Table 13.6. Intervention. Offer small, high-calorie and high-protein snacks frequently throughout the day and evening. Low weight and poor nutrition render the patient susceptible to illness. Small, frequent snacks are more easily tolerated than large plates of food when the patient is anorexic. Offer high-protein and high-calorie fluids frequently throughout the day and evening. When possible, encourage family or friends to remain with the patient during meals. These fluids prevent dehydration and can minimize constipation. This strategy reinforces the idea that someone cares, can raise the patient's self-esteem, and can serve as an incentive to eat. Ask the patient which foods or drinks he or she likes. Offer choices. Involve the dietitian. Weigh the patient weekly and observe the patient's eating patterns. The patient is more likely to eat the foods provided if they have a choice. Monitoring the patient's status gives the information needed for revision of intervention. Now for sleep and insomnia. Provide periods of rest after activities. Fatigue can intensify feelings of depression. Encourage the patient to get up and dress and stay out of bed during the day. Minimizing sleep during the day increases the likelihood of sleep at night. Encourage the use of relaxation measures in the evening, e.g. tepid bath, warm milk. These measures induce relaxation and sleep. Reduce environmental and physical stimulants in the evening. Provide decaffeinated coffee, soft lights, soft music, and quiet activities. Decreasing caffeine and epinephrine levels increase the possibility of sleep. Self-care deficits. Encourage the use of toothbrush, washcloth, soap, makeup, shaving equipment, and so forth. Being clean and well-groomed can temporarily increase self-esteem. When appropriate, give step-by-step reminders such as wash the right side of your face, now the left. Slowed thinking and difficulty concentrating make organizing simple tasks difficult. Okay, now for elimination and constipation. Monitor intake and output, especially bowel movements. Many patients with depression are constipated. If the condition is not checked, fecal impaction can occur. Offer foods high in fiber and provide periods of exercise. Roughage and exercise stimulate peristalsis and help evacuation of fecal material. Encourage the intake of fluids. Fluids help prevent constipation. Evaluate the need for laxatives and enemas. These measures prevent fecal impaction. Pharmacological interventions. Because mood disorders are caused by problems with neurotransmitters, it follows that medications that alter brain chemistry are an important component in the treatment of them. Antidepressant therapy benefits from about 80% of people with major depression. It should be noted, however, that combination of specific psychotherapies, e.g. CBT, IPT, behavioral, and antidepressant therapies is superior to either psychotherapy or psychopharmacological treatment. So combination is better than just one. Antidepressant drugs. Antidepressant drugs can positively alter poor self-concept, degree of withdrawal, vegetative signs of depression, and activity level. Target symptoms include sleep disturbance, appetite disturbance, decreased or increased, fatigue, decreased sex drive, psychomotor retardation or agitation, diurnal variations in mood, often worse in the morning, impaired concentration or forgetfulness, anhedonia, loss of ability to experience joy or pleasure in living. A drawback of antidepressant drugs is that improvement in mood may take 1 to 3 weeks or longer. If a patient is acutely suicidal, electroconvulsive therapy, discussed in detail later in this chapter, can be a reliable and effective alternative. The goal of antidepressant therapy is the complete remission of symptoms. Often, the first antidepressant prescribed is not the one that will ultimately bring about remission. Aggressive treatment helps in finding the proper treatment. An adequate trial for the treatment of depression is 3 months. Individuals experiencing their first depressive episode are maintained on antidepressants for 6 to 9 months. After symptoms of depression remit, some people may have multiple episodes of depression or may have a chronic form, similar to the chronicity of diabetes, and benefit from indefinite antidepressant therapy. Antidepressants may precipitate a psychotic episode in a person with schizophrenia or a manic episode in a patient with bipolar disorder. Patients with bipolar disorder often receive a mood-stabilizing drug along with an antidepressant. Choosing an antidepressant. All antidepressants work to increase the availability of one or more of the neurotransmitters serotonin, norepinephrine, and dopamine. All antidepressants work equally well. However, a variety of antidepressants or a combination of antidepressants may need to be tried before the most effective regimen is found for an individual patient. Each of the antidepressants has different adverse effects, costs, safety issues, and maintenance considerations. Selection of the appropriate antidepressant is based on the following considerations. Side effect profile, e.g. sexual dysfunction, weight gain, ease of administration, history of past response, safety and medical considerations. Table 13.7 provides an overview of antidepressant use in the United States. Selective serotonin reuptake inhibitors. The selective serotonin reuptake inhibitor, SSRI, are recommended as first-line therapy for most types of depression. Essentially, the SSRIs selectively block the neuronal uptake of serotonin. E.g. 5-HT, 5-HT1 receptors, which block the neuronal uptake of serotonin. And they increase the availability of serotonin in the synaptic cleft. Refer to Chapter 3 for a more detailed discussion of how SSRIs work. SSRI antidepressant drugs have a relatively low side effect profile compared with the older antidepressants, tricyclics, discussed later in this chapter. They do not create dry mouth, blurred vision, or urinary retention, make it easier for patients to take these medications as prescribed. Adherence to the medication regimen is a crucial step toward recovery or remission of symptoms. The SSRIs are effective in depression with anxiety features and depression with psychomotor agitation. Because SSRIs cause relatively few adverse effects and have low cardiotoxicity, they are less dangerous than older antidepressants when taken in overdose. The SSRIs, selective serotonin norepinephrine reuptake inhibitors, or SNRIs, and atypical antidepressants have a low lethality risk in the suicide attempts, whereas the tricyclic antidepressants have a very high potential for lethality with overdose. Indications. The SSRIs have a broad base of clinical use. In addition to their use in treating depressive disorders, the SSRIs have been prescribed with success to treat some of the anxiety disorders, in particular obsessive-compulsive disorder and panic disorder. See Chapter 12. Fluoxetine, fluoxetine has been found to be effective in treating some women who suffer from late luteal phase dysphoric disorder and bulimia nervosa. Common adverse reactions. Agents that selectively enhance synaptic serotonin within the CNS may induce agitation, anxiety, sleep disturbance, tremor, sexual dysfunction, primarily anorgasmia, or tension headache. The effect of the SSRIs on sexual performance may be the most significant undesirable outcome reported by patients. Autonomic reactions, e.g. dry mouth, sweating, weight change, mild nausea, and loose bowel movements, may also be experienced with the SSRIs. Potential toxic effects. One rare and life-threatening event associated with SSRIs is serotonin syndrome. This syndrome is thought to be related to overactivation of the central serotonin receptors caused by either too high a dose or interaction with other drugs. Symptoms include abdominal pain, diarrhea, sweating, fever, tachycardia, elevated blood pressure, altered mental state, delirium, myoclonus, muscle spasms, increased motor activity, irritability, hostility, and mood change. Severe manifestations can induce hyperpyrexia, excessively high fever. That's what hyperpyrexia is. Cardiovascular shock or death. The risk of this syndrome seems to be greatest when an SSRI is administered in combination with a second serotonin-enhancing agent, such as a monoamine oxidase inhibitor, MAOI. A patient should discontinue all SSRIs for 2 to 5 weeks before starting an MAOI. 2 to 5 weeks before that. Okay. Box 13.2 lists the signs and symptoms of serotonin syndrome and gives emergency treatment guidelines. Box 13.3 is a useful tool for patient and family teaching about the SSRIs. Tricyclic antidepressants. The tricyclic antidepressants, TCAs, inhibit the reuptake of norepinephrine and serotonin by the presynaptic neurons in the CNS, increasing the amount of time norepinephrine and serotonin are available to the postsynaptic receptors. This increase of norepinephrine and serotonin in the brain is believed to be responsible for mood elevations. Drug treatment of patients with major depression. I'm not going to go through all of this. First line of treatment for major depression is serotonin, is the SSRIs. It blocks reuptake of serotonin. List of these would be Celexa, Lexapro, Prozac, Luvox, Paxil, and Zoloft. Discontinuation syndrome, dizziness, insomnia, nervousness, irritability, nausea, and agitation may occur with abrupt withdrawal. That's what discontinuation syndrome is. So don't draw abruptly or you can get those things. Depending on half-life, so taper off slowly. Contraindicated in people taking MAOIs. Some SRIs activate and others sedate. Choice depends on patient's symptoms. Risk of lethal overdose minimized with SSRIs. Okay, so SNRIs are like Effexor and Cymbalta. They block reuptake of serotonin and norepinephrine. Effexor is popular next step strategy after trying SSRIs. Cymbalta has the advantage of decreasing neuropathic pain. You get hypertension, nausea, insomnia, dry mouth, sweating, agitation, headache, sexual dysfunction for side effects. You should monitor blood pressure for Effexor, especially at higher doses. And with a history of hypertension, discontinuation syndrome, also as the same as SSRIs, so taper off of it. Also contraindicated for people taking MAOIs. There's also NRIs. I don't think these are too important. Effects are similar to SSRIs and TCAs, useful with severe depression and impaired social functioning. Vestra is the big one on that. This blocks the reuptake of norepinephrine and enhances transmission. Contraindicated in MAOIs. There's serotonin receptor antagonists or agonists, and those work to block the serotonin 2 receptors and some adrenergic receptors. Nefazodone. They have a lower risk of long-term weight gain than SSRIs. Lower risk of sexual side effects. Life-threatening liver failure is possible but rare. Priapism of penis and clitoris is rare but serious side effect. There are also NDRIs, norepinephrine dopamine reuptake inhibitors. That one was Wellbutrin. That blocks the reuptake of norepinephrine and dopamine. Stimulant action may reduce appetite, may increase sexual desire. Used as an aid to quit smoking, agitation, insomnia, headache, vomiting, seizures, 0.4%. With Wellbutrin, contraindicated for people taking MAOIs. High dose increases seizure risk, especially in people who are predisposed to them. So that one's contraindicated for seizures, and that's Wellbutrin. Serotonin norepinephrine disinhibitors, SNDIs. That's Remeron. Normally inhibits norepinephrine and serotonin. Antidepressant effects equal to SSRIs and may occur faster. You can have weight gain, dizziness, sexual dysfunction. Watch for drug-induced somnolence, exaggerated by alcohol, benzodiazepines, and other CNS depressants, contraindicated for MAOIs. TCAs. You got Elavil, Anafranil, Norapramin, Adipin Sinequan, Tofranil, Aventil, Pamelor, Vivactil. This inhibits the reuptake of serotonin and norepinephrine, antagonizes adrenergic, histaminergic, and muscarinic receptors. Therapeutic effects similar to SSRIs, but side effects are more prominent, may work better in melancholic depression. TCAs can worsen many cardiac and medical conditions: dry mouth, constipation, urinary retention, blurred vision, orthostatic hypotension, cardiac toxicity, and sedation. Watch out for the lethal overdose. Use cautiously in older adults and those with cardiac disorders, elevated intraocular pressure, urinary retention, hyperthyroidism, seizure disorders, and liver or kidney dysfunction, contraindicated in people taking MAOIs. And then MAOIs, monooxidase inhibitors. You've got Nardil, Emsam, and Parnate. This inhibits the enzyme monoamine oxidase, which normally breaks down neurotransmitters, including serotonin and norepinephrine. so it doesn't break them down, it just lets them live. Efficacy, similar to other antidepressants, but dietary restrictions and potential drug interactions make this drug less desirable. That's with tyramine, anything with tyramine in it. Insomnia, nausea, agitation, confusion. These are side effects. Potential for hypertension, crisis, or serotonin syndrome with concurrent use of other antidepressants. Contraindicated people taking other antidepressants. Tyramine-rich food could bring about a hypertensive crisis. Many other drug interactions. Lots and lots. Box 13.2, serotonin syndrome, symptoms and interventions. Oh my gosh, we just went over all this, but hyperactivity or symptoms. Hyperactivity or restlessness, tachycardia equals cardiovascular shock, fever or hyperpyrexia, elevated blood pressure, altered mental states, delirium, rationality, mood swings, hostility, seizures, status epilepticus, myoclonus, incoordination, tonic rigidity, abdominal pain, diarrhea, bloating, apnea, death. Apnea causes death. Interventions: remove offending agents, initiate symptomatic treatment, serotonin receptor blockade with cyproheptadine, methotrexate, propranolol. So, I guess, I don't know. Cooling blankets, chloropromazine for hyperthermia, dantrolene, diazepam for muscle rigidity or rigors, anticonvulsants, artificial ventilation, paralysis. That's an intervention, is paralysis? I don't understand. Okay. Paralyze them. Okay, indications. The sedative effects of the TCAs are attributed to the blockade of histamine receptors. Patients must take therapeutic doses of TCAs for 10 to 14 days or longer before they begin to work. Full effects may not be seen for 4 to 8 weeks. An effect on some symptoms of depression, such as insomnia or anorexia, may be noted earlier. Choosing a TCA for a patient is based on what has worked for the patient or family member in the past and the drug's adverse effects. A stimulating TCA such as despermine or norpramine or protriptyline or Vivactil may be best for a patient who is lethargic and fatigued. If more sedating effect is needed for agitation or restlessness, drugs such as amitriptyline, Elavil, and doxepin, Sinequin may be more appropriate choices. Regardless of which TCA is given, the initial dose should always be low and increase gradually. Common adverse reactions: the chemical structure of the TCAs closely resembles that of antipsychotic medications, and the anticholinergic actions are similar, e.g. dry mouth, blurred vision, tachycardia, constipation, urinary retention, and esophageal acid reflux. These side effects are more common and more severe in patients taking antidepressants. They usually are not serious and are often transitory, but urinary retention and severe constipation warrant immediate medical attention. Weight gain is also a common complaint among people taking TCAs. Box 13.3, patient and family teaching selective serotonin reuptake inhibitors. May cause sexual dysfunction, lack of sex drive, inform nurse or primary care provider if this occurs. May cause insomnia, anxiety, and nervousness, inform if this occurs. May interact with other medications, inform if this occurs, especially if taking digoxin, warfarin. SSRIs should not be taken within 14 days of the last dose of a MAOI. No over-the-counter drugs should be taken without first notifying primary care provider. Common side effects include fatigue, nausea, diarrhea, dry mouth, dizziness, tremor, and sexual dysfunction or lack of sex drive. Because of the potential for drowsiness and dizziness, patients should not drive or operate machinery until the side effects are ruled out. Alcohol should be avoided. Liver and renal function tests should be performed and blood counts checked periodically. Medications should not be discontinued abruptly if side effects become bothersome. Patients should ask primary care provider about changing to a different drug. Abrupt cessation can lead to a serotonin withdrawal. Any of the following symptoms should be reported to the primary care provider immediately: increase in depression or suicidal thoughts, rash or hives, rapid heartbeat, sore throat, difficulty urinating, fever, malaise, anorexia, and weight loss, unusual bleeding, initiation of hyperactive behavior, severe headache. The adrenergic blockade of the TCAs can produce postural. Now I'm back to TCAs. The adrenergic blockade of the TCAs can produce postural orthostatic hypertension and tachycardia. Postural hypertension can lead to dizziness and increase the risk of falls. Duh. Sorry, this is getting a little repetitive. Administering the total daily dose of TCA at night is beneficial for two reasons. First, most TCAs have sedative effects and thereby aid sleep. Second, the minor side effects occur while the individual is sleeping, which increases compliance with drug therapy. Potential toxic effects. The most serious effects of the TCAs are cardiovascular dysrhythmias, tachycardia, myocardial infarction, and heart block, which have been reported. Because the cardiac side effects are so serious, TCA use is considered a risk in older adults and patients with cardiac disease. Patients should have a thorough cardiac workup before beginning a TCA therapy. Adverse drug interactions. Oh, we've been through this, but use of an MAOI along with TCA is contraindicated. A few of the more common medications usually not given with TCAs are being used as listed in box 13.4. A patient who is taking any of these medications along with a TCA should have medical clearance because some of the reactions can be fatal. Contraindications. People who have recently had myocardial infarction or other cardiovascular problems, those with narrow angle glaucoma or a history of seizures, and women who are pregnant should not be treated with TCAs except with extreme caution and careful monitoring. Patient and family teaching. Areas for the nurse to discuss when teaching patients and their families about TCA therapy are presented in box 13.5. Here's a list of foods that you can't have with MAOIs. Vegetables would be avocados, especially overripe fermented bean curd, fermented soybean, and soybean paste. Most vegetables are safe. Fruits, figs, especially if overripe, bananas in large amounts, but most fruits are safe. Meats that are fermented, smoked, or otherwise aged, spoiled meats, liver unless very fresh. Meats are known to be fresh. Exercise caution in restaurants. Meats may not be fresh. Sausages, fermented varieties, bologna, pepperoni, salami, others. Fish, dried or cured fish, fish that is fermented, smoked, or otherwise aged. Anything aged or smoked. Milk, practically all cheeses, just don't eat them. Yeast extract would be Marmite or Bovril. Marmite. Beer wine, some imported beers and Chianti wines. Major domestic brands of beer, most wines are okay. Other foods. Protein dietary supplements, soups may contain protein extract, shrimp paste, soy sauce. Here's some foods that contain vasopressors, also contraindicated for MAOIs. Chocolate, fava beans, ginseng, caffeinated beverages. So, let's skip through a lot of that. Okay, use of antidepressants by pregnant women. Within the last few years, there have been increasing concerns about the safety of antidepressants taken during pregnancy. Early studies demonstrated an association between TCAs and congenital malformations of the heart and limbs, and MAOI's use has been associated with severe hypertension and stroke. Use of SSRIs has been associated with breathing problems and withdrawal symptoms in infants. One study indicated that women who took either SSRIs or TCAs had an increased risk of preterm birth. Another study demonstrated a higher risk for spontaneous abortion with use of antidepressants. Although these problems have been documented, the overall risk remains small, and untreated depression presents its own problems. Pregnant women with depression have a higher risk of preterm birth. Low birth weight infants, substance abuse, and nicotine use. The decision to take antidepressants while pregnant is one that must be made by carefully weighing the risks and benefits involved. Use of antidepressants by children and adolescents. In 2005, the U.S. Food and Drug Administration, FDA, issued a black box warning for all antidepressants, alerting the public to the increased risk of suicidal thinking or attempts in children or adolescents taking antidepressants. Following the black box warning, the number of prescriptions written for SSRIs for children and young adults decreased, but suicides in those age groups actually increased. Dudley and colleagues concluded that the risk for suicide is greater in children and adolescents with depression who do not take antidepressants. To minimize the risk of suicide in people taking antidepressants, close monitoring by healthcare professionals and patient caregiver education are essential. Chapter 24 has more detailed discussion of suicide risk factors and warning signs. The use of antidepressants by older adults. Polypharmacy and the normal process of aging contribute to concerns about prescribing antidepressants for older adults. SSRIs are a first-line treatment for older adults, but they have the potential for aggravated side effects. Starting doses are recommended to be half the lowest adult dose, with dose adjustments occurring no more frequently than every 7 days. TCAs and MAOIs have side effect profiles that are more dangerous for older adults, specifically cardiotoxicity with TCAs and hypertension with both classes. Any medication with the side effect of hypertension or sedation in older adults increases the risk of falls. Older adults should be cautioned against abrupt discontinuation of antidepressants because of the possibility of discontinuation syndrome, which causes anxiety, dysphoria, flu-like symptoms, dizziness, excessive sweating, and insomnia. Electroconvulsive therapy. This one's important. Despite being a highly effective somatic physical treatment for psychiatric disorders, electroconvulsive therapy, ECT, has a bad reputation. This may be due to media portrayals of patients being restrained on a gurney while having a full-blown seizure induced. Given the current sophistication of anesthetic and paralytic agents, ECT is actually not dramatic at all. Another possible reason for ECT's stigmatized status is how it works remains a mystery. Although researchers have speculated as to its mechanism of action, it is likely that the seizure that is induced results in mobilization and activity of neurotransmitters. Indications. ECT is used most commonly for depression. While as many as 50% of people taking antidepressants fail to achieve full remission, clinical trials of ECT report a rate of 70 to 90% remission. Suicidal thoughts respond to ECT in 80% of cases. Psychotic illnesses are the second most common indication of ECT. For drug-resistant patients, a combination of ECT and antipsychotic medication has resulted in sustained improvement about 80% of the time. While medication is generally the first line of treatment, according to SADOC, ECT may be a primary treatment in the following cases. When a patient is suicidal or homicidal and there is a need for a rapid definitive response. If previous medication trials have failed. When there is marked agitation, marked vegetative symptoms, or catatonia. For major depression with psychotic features. ECT is useful in treating patients with major depression, especially when psychotic symptoms are present. Patients who have depression with marked psychomotor symptoms are retardation and stupor also respond well. ECT is also indicated for manic patients whose conditions are resistant to treatment with lithium and antipsychotic drugs, and for rapid cyclers. A rapid cycler is a patient with bipolar disorder who has many episodes of mood swings close together, 4 or more in 1 year. People with schizophrenia, especially catatonic, those with schizoaffective syndromes, psychotic patients who are pregnant, and patients with Parkinson's disease can also benefit from ECT. ECT is not necessarily effective, however, in patients with DD, atypical depression, personality disorders, drug dependence, or depression secondary to situational or social difficulties. The usual course of ECT for a patient with depression is 2 to 3 treatments per week, to a total of 6 to 12 treatments. Although no absolute contraindications to ECT exist, several conditions pose risks and require careful workup and management. Since the heart can be stressed at the onset of the seizure and for up to 10 minutes after, careful assessment of management in hypertension, congestive heart failure, and cardiac arrhythmias, and other cardiac conditions is warranted. ECT also stresses the brain as a result of increased cerebral oxygen, blood flow, and intracranial pressure. Conditions such as brain tumors and subdural hematomas may increase the risk of using ECT. Providers of care and patients need to weigh the risk of continued disability or potential suicide from depression against ECT treatment risks. Initiating electroconvulsive therapy. The procedure is explained to the patient, and informed consent is obtained if the patient is being treated voluntarily. For a patient treated involuntarily, permission may be obtained from next of kin. Although in some states treatment must be court-ordered, the patient is usually given a general anesthetic to induce sleep, e.g. a short-acting barbiturate such as methotrexate sodium, Brevitol, and a muscle-paralyzing agent, e.g. succinylcholine, to prevent muscle distress and even fractures. These medications have revolutionized the comfort and safety of ECT. An electroencephalogram, EEG, monitors brain waves. An electrocardiogram, ECG, monitors cardiac response. Brief seizures, 30 to 60 seconds, are deliberately induced by an electric current as brief as 1 second, transmitted through electrodes attached to one or both sides of the head. Potential adverse reactions. Patients wake about 15 minutes after the procedure. After awakening from ECT, the patient may be confused and disoriented. The nurse and family may need to orient the patient frequently during the course of treatment. Many patients state that they have memory deficits for the first few weeks after the course of treatment, but memory usually, although not always, recovers. ECT is not a permanent cure for depression, and maintenance treatment with TCAs or lithium decreases the relapse rate. Maintenance ECT once a week to once a month may also help to decrease relapse rates for patients with recurrent depression. Transcranial magnetic stimulation. Transcranial magnetic stimulation, TMS, is a non-invasive treatment modality that uses MRI strength magnetic pulses to stimulate focal areas of the cerebral cortex. Mitchell and Liu, 2006, analyzed 25 studies involving the use of TMS for patients with depression and concluded that benefits were statistically significant and treatment was safe. Ongoing research is needed to determine optimum treatment guidelines, frequency, intensity, and duration, and who would benefit most from this type of procedure. Indications. In 2008, the United States Food and Drug Administration, FDA, approved the use of TMS for patients who have been unresponsive to other methods of treatment for depression. A large-scale multi-site randomized controlled trial reported that TMS is an effective standalone without antidepressants treatment. Studies have been conducted and are underway to research the safety and efficacy of TMS in the treatment of schizophrenia, anxiety disorders, and pain. Evidence-based practice, electroconvulsive therapy in older adults. Problem. Electroconvulsive therapy, ECT, remains an effective treatment option for people experiencing late-life depression. However, the decision-making process of older adults opting for ECT remains largely misunderstood. Nurses must have a better understanding of this process in order to assist older adults as they make decisions about whether or not to have ECT. Purpose of study. The purpose of the study was to explore the decision-making process of older adults electing to receive ECT. Methods. 7 older adults between the ages of 60 and 90 who had received ECT participated in this exploratory phenomenological study. Each participant engaged in a 1-hour in-depth interview in which they were asked to describe the process of deciding to receive ECT. The participants' responses were analyzed for common themes. Key findings. 4 key themes that emerged were trust in family, their physician and God, support from family, friends, and significant others, past experience with positive results from ECT, either for themselves or a friend or acquaintance, a sense of desperation for the need to get well. The overriding substantive theme involved the negative impact of the stigma of both mental illness and ECT. Participants feared what other people would think if knowledge of their ECT was made known. Implications for nursing practice. In addition to providing education and information to older adults considering whether or not to receive ECT, psychiatric mental health nurses must also work to break through the stigma and discrimination these patients face. Initiating transcranial magnetic stimulation. Okay, so back to TMS. Outpatient treatment with TMS takes about 30 minutes and is typically ordered for 5 days a week for 4 to 6 weeks. Patients are awake and alert during the procedure. An electromagnet is placed on the patient's scalp and short magnetic pulses pass into the prefrontal cortex of the brain. These pulses are similar to those used by MRI scanners but are more focused. The pulses cause electrical charges to flow and induce neurons to fire or become active. During TMS, patients feel a slight tapping or knocking in the head, contractions of the scalp, and tightening of the jaws. Potential adverse reactions. After the procedure, patients may experience a headache and lightheadedness. No neurological deficits or memory problems have been noted. Seizures are a rare complication of TMS. One research study that analyzed 10,000 treatment sessions reported no occurrence of seizures. Most of the common side effects of TMS are mild and include scalp tingling and discomfort at the administration site. Vagus nerve stimulation, VNS. The use of vagus nerve stimulation originated as a treatment for epilepsy. Clinicians noted that while VNS decreased seizures, it also appeared to improve mood in a population that normally experiences increased rates of depression. The theory behind VNS relates to the action of the vagus nerve, the longest cranial nerve, which extends from the brainstem to the organs in the neck, chest, and abdomen. Researchers believe that electrical stimulation of the vagus nerve results in boosting the level of neurotransmitters, thereby improving mood and also improving the action of antidepressants. Indications. Nearly a decade after VNS was approved for use in Europe, the FDA granted approval for VNS in the United States for treatment-resistant depression. The efficacy of VNS in treating depression is still being established. Other potential applications of VNS include anxiety, obesity, and pain. Initiating vagus nerve stimulation. The surgery to implant VNS is typically outpatient. A pacemaker-like device is implanted surgically into the left chest wall. The device is connected to a thin, flexible wire that is threaded up and wrapped around the vagus nerve on the left side of the neck. After surgery, an infrared magnetic wand is held against the chest, while a personal computer or personal digital assistant, PDA, is used to program the frequency of pulses. Pulses are usually delivered for 30 seconds every 5 minutes for 24 hours a day. Antidepressant action typically occurs in several weeks. Potential adverse reactions of a VNS is a surgical procedure carrying with it the risks inherent in any surgical procedure, e.g. pain, infection, sensitivity to anesthesia. Side effects of active VNS therapy are due to the proximity of the lead on the vagus nerve, which is close to the laryngeal and pharyngeal branches of the left vagus nerve. Voice alteration occurs in nearly 60% of patients. Other side effects include neck pain, cough, paresthesia, and dyspnea, which tend to decrease with time. The device can be turned off at any time by placing a special magnet over the implant. This may be especially helpful when engaging in public speaking or heavy exercise. Integrative therapy. Pilkington, Ramps, and Richardson, 2006, highlight an array of complementary, alternative, and integrative approaches in the treatment of depression, including the use of dietary supplements, acupuncture, aromatherapy, meditation, light therapy, homeopathy, and yoga. Herbal products and supplements for depression have become a multi-million-dollar industry. However, the long-term effects of these products have just begun to be studied. Pilkington and colleagues warn that because many of these methods are not well supported by research, they should be used with caution. The approach briefly discussed here are light therapy, use of St. John's wort, and exercise. Light therapy. Light therapy has been researched for nearly 20 years and is accepted as a first-line treatment for seasonal affective disorder. People with SAD often live in regions in which there are marked seasonal differences in the amount of daylight, which is thought to disrupt melatonin production, circadian rhythms, or the ability to process dopamine and norepinephrine. Whatever the cause, the effect is a seasonal depression. Light therapy may also be useful as an adjunct in treating chronic MDD or DD with seasonal exacerbations. Light therapy is thought to be effective because of the influence of light on melatonin. Melatonin is secreted by the pineal gland and is necessary for maintaining and shifting biological rhythms. Exposure to light suppresses the nocturnal secretion of melatonin, which seems to have a therapeutic effect on people with SAD. Ideal treatment consists of 30 to 45 minutes of exposure daily to 10,000 lux light source. Morning exposure is best, however, success has been reported when exposure occurs at other times of the day or in divided doses. Anecdotal reports suggest that increasing the available light by adding additional light sources may also help to elevate mood. For those affected by SAD, light therapy has been found to be as effective in reducing depressive symptoms as medications. Negative side effects include headache, eye strain, and rarely hypomania. Concerns about eye damage from light exposure have not been validated. St. John's wort. St. John's wort, or Hypericum perforatum, is a flower that can be processed into tea or tablets. It is thought to increase the amount of serotonin, norepinephrine, and dopamine in the brain, resulting in antidepressant effects. Excuse me. Studies of St. John's wort used in the treatment of depression offer mixed results. It has generally been found to be effective as antidepressants in the treatment of mild to moderate depression, but usefulness in severe depression has not been established. Because St. John's wort is not regulated by the FDA, concentrations of the active ingredient may vary from preparation to preparation, which may account for some variation in research results. St. John's wort has the potential for adverse reactions when taken with other medications, and safety has not been established for use during pregnancy or in children. Exercise. Substantial evidence suggests that exercise can enhance mood and counteract symptoms of depression. Reports that the effects of exercise on symptoms of depression are biological, social, and psychosocial. Research shows that exercise increases available serotonin, typically low in depression. It also has been demonstrated to dampen the activity of the hypothalamic pituitary adrenocorticoid HPA axis, which is believed to be overly active in depression. People with depression who exercise regularly report feeling an elevated mood, greater happiness, and being more socially involved. Additional benefits of exercise are that it is more easily accessed, less expensive, and results in fewer side effects than antidepressants. American Psychiatric Association. Practice Guidelines for the Treatment of Psychiatric Disorders. Compendium 2000, Washington, D.C. author. What am I reading that for? Okay. Advanced Practice Interventions. The advanced practice nurse is qualified to provide psychotherapy, social skills, training, and group therapy. In some states, nurses who have met appropriate educational standards may be certified to prescribe medication to treat depression. Psychotherapy, cognitive behavioral therapy, CBT, interpersonal therapy, IPT, time-limited focused psychotherapy, and behavioral therapy all are especially effective in the treatment of depression. However, only CBT and IPT demonstrate superiority in the maintenance phase. CBT helps people change their negative thought patterns and behaviors, whereas IPT, interpersonal therapy, focuses on working through personal relationships that may contribute to depression. Group therapy. Group therapy is a widespread modality for treatment of depression. It increases the number of people who can receive treatment at a decreased cost per individual. Another advantage is that groups offer patients an opportunity to socialize and share common feelings and concerns, which decreases feelings of isolation, hopelessness, helplessness, and alienation. Future of treatment. There is a great need for early detection, earlier intervention, prevention of progression, achievement of remission, and integration of neuroscience and behavioral science in the treatment of depression. Goals include improved screening for high-risk ages and groups including individuals in late adolescence and early adulthood, women in reproductive years, adults and older adults with medical problems, e.g. pain, and people with a family history of depression. Increase education, particularly about the linkage between physical symptoms and depression. Psychopharmacological treatment augmented with cognitive behavioral therapies. Inclusion of more supplementary strategies such as promotion of sleep hygiene. Increase in exercise, better overall care. Evaluation. Short-term indicators and outcome criteria for frequently evaluated during the course of treatment for depression. For example, if the patient with depression came into the unit with suicidal thoughts, the nurse evaluates whether suicidal thoughts are still present. The person is able to state alternatives to suicidal impulses in the future. The patient is able to explore thoughts and feelings that precede suicidal impulses, and so forth. Outcomes related to thought processes, self-esteem, and social interactions are frequently formulated because these areas are often problematic in people with depression. Physical needs warrant nursing or medical attention. If a patient has lost weight because of anorexia, is the appetite returning? If the patient was constipated, are the bowels now functioning normally? If the patient was suffering from insomnia, is sleep improving to 6 to 8 hours of sleep per night? If indicators have not been met, an analysis of the data, nursing diagnosis, goals, and planned nursing interventions is made. The care plan is reassessed and reformulated as necessary. Key points to remember. Depression is the most common psychiatric disorder. There are a number of subtypes of depression and the depressive clinical phenomena. The two primary depressive disorders are major depressive disorder, MDD, and dysthymic disorder, DD. The symptoms of major depression are usually severe enough to interfere with a person's social or occupational functioning. A person with MDD may or may not have psychotic symptoms, and the symptoms usually exhibited during an episode of major depression are different from the characteristics of the normal premorbid personality. The symptoms of DD are often chronic, lasting 2 years, and are considered mild to moderate. Usually a person's social or occupational functioning is not greatly impaired. The symptoms in DD are often congruent with the person's usual pattern of functioning. Many theories exist about the cause of depression. The most accepted is psychophysiological theory. However, cognitive theory, learned helplessness theory, and the diathesis theory, stress theory, help explain triggers to depression and maintenance of depressive thoughts and feelings. Nursing assessment includes the evaluation of affect, thought processes, especially suicidal thoughts, mood, feelings, physical behavior, communication, and religious beliefs and spirituality. The nurse also must be aware of the symptoms that may mask depression. Nursing diagnosis can be numerous. Individuals with depression are always have elevated risk for suicide. Some other common nursing diagnoses are disturbed thought processes, chronic low self-esteem, imbalanced nutrition, constipation, disturbed sleep pattern, ineffective coping, and disabled family coping. Working with people who have depression can evoke intense feelings of hopelessness and frustration in healthcare workers. Nurses must clarify expectations of themselves and their patients and sort personal feelings from those communicated by the patient via empathy. Peer supervision and individual supervision by an experienced nurse clinician, psychiatric social worker, or psychologist are useful in increasing therapeutic potential. Interventions with patients who have depression involve severe approaches. Basic level interventions include using specific principles of communication, planning activities of daily living, administering or participating in psychopharmacological therapy, maintaining a therapeutic environment, and teaching patients about the biochemical aspects of depression. Advanced practice interventions may include several short-term psychotherapies that are effective in the treatment of depression, including IPT, CBT, skills training, assertiveness and social skills, and some forms of group therapy. Depression is often overlooked in children, adolescents, and older adults because symptoms of depression are often mistaken for signs of normal development. Planning and interventions for patients with depression are based on the recovery model, which involves a therapeutic alliance with healthcare professionals in order to achieve outcomes based on individual patients' needs and values. Evaluation is ongoing throughout the nursing process, and patients' outcomes are compared with the stated outcome criteria in short-term and intermediate indicators. The care plan is revised when indicators are not being met. The end. All right. That was Varcarolis, Chapter 13, Depressive Disorders.